Okay, we are live.
Yeah,
We are live?
just a minute. Just a minute, yeah. 2 seconds. Yes. Good afternoon, everyone in India, and good evening, everyone in Korea. Well, we welcome you all to Navi Mumbai Orthopedic Association NMOA webinar series. Today, we have our international speaker, Professor Jeon. He is a shoulder specialist from Asan Medical Center, Seoul, South Korea. And the panelists are two of his ex-fellows, Dr. Ashay Kekatpure and Dr. Prasad Chaudhary. I would hand over the proceedings to Dr. Ashay Kekatpure to please introduce the professor.
Good evening, everyone. I'm Dr. Ashay. I had the pleasure and I was fortunate enough to undergo my shoulder training with Professor Jeon at Asan Medical Center, Seoul, South Korea. I had a radical change in my thinking towards shoulder surgery. I have followed Professor Jeon step by step in his shoulder surgeries, and I'm very happy that he has agreed for participating in a web-based seminar and to share his experience on massive rotator cuff. Professor Jeon is a prolific shoulder and elbow surgeon. On an average, there are almost 1,000 cases per year, and shoulder replacements, all kind of shoulder surgeries around. He is one of the only person who is editor for the Journal of Asian person, who is the general editor for the Journal of Shoulder Elbow Surgery. And it is our immense pleasure to invite him on the NMOA platform. Over to you, Professor Inho.
Dr. Ashay Kekatpure, thank you very much. And it's a real big pleasure and truly honored to be invited to Navi Mumbai Indian shoulder surgeons. And I'm also very happy to meet Dr. Prasad and Ashay again through online. And here today, I'd like to share how we do massive rotator cuff management in South Korea with you. So is it okay I share my slides?
Yes, please go ahead.
Okay, so how do you see, can you see clear?
Yes, we can see it.
All right, thank you very much. And today, I'd like to share what sort of basic science issues we should know before we do a rotator cuff surgery. And second part will be my preferred management for massive rotator cuff tear. So before I start my talk, I'd like to show you how Asan Medical Center looks like. This is the biggest medical center in South Korea. And here Dr. Prasad and Ashay Kekatpure stayed with us. And we had a really amazing, very impressive work together. And these two fellows, they changed my clinical practice a lot because they gave me a lot of innovative, creative ideas. And when the COVID-19 issue is over, I welcome you again to Asan Medical Center so that we can have a face-to-face discussion and collaboration together. So, first part, what kind of basic science we should know when we do a rotator cuff surgery? I know surgeons don't like basic science, but at least these issues you should be aware of before you do a surgery. So basically, rotator cuff tear and aging issue. We know the rotator cuff tear is an aging process. A lot of literature support that as you get old, you have more rotator cuff tear. So the study 2009, you see the 80% of full thickness tear actually occur in people over 80. So think about it. In age over 80, rotator cuff tear, is it really a disease? Is it really a pathology or is it normal? You know, one of the normal findings. So whenever I see the patient, I ask myself, rotator cuff tear is a spectrum of disease. Before the white light comes to the prism, it's one. But after prism, it shows all different color. So rotator cuff tear, it sounds like one disease, but it's not really one disease. It can be very acute traumatic. It can be very chronic degenerative, or sometimes it's acute on chronic. So this is important because rotator cuff tear size is important. We know the small, medium size, they do really well. Large, massive, it's very challenging for treating surgeons. And at the same time, all these different kind of rotator cuff tear, you cannot treat with a single stress day. So how we should do that? We need a little bit of idea to manage this rotator cuff. This is my way of thinking. So whenever a patient comes to me with rotator cuff tear, I always ask myself, is it acute tear or is it chronic tear? Or is this a traumatic tear or is this degenerative tear? Or is this a small size tear or is it large size tear? So if the patient is included in an acute traumatic small size tear, I know the outcome will be very good. But if patient is a large degenerative chronic tear, it's a completely different disease. It's a completely different disease entity. So a few basic signs we should know before treat the rotator cuff. This is a rotator cuff tear. You know the tear starts from 15 millimeter behind the long head of biceps. So as you can see here, this is long head of biceps. Here is the point where you start rotator cuff tear. And then this tear initiates and then progression front and back. So if you look very carefully, this is a humeral head, long head of biceps. This is the cable of rotator cuff. So any tear which involves this rotator cable can have a higher chance of progression. So this rotator cable is an important anatomic structure according to the Burkhardt because it holds a lot of tensile load and it resists tear progression. So this is how we do a rotator cuff surgery. You see that from articular side, the bursa side, here you can have a long head of biceps in the front, and left shoulder, you can put the two medial anchor in a medial side, and then pass sutures and suture relay. And then after passing all these sutures, you can make a knot in the medial, or sometimes you don't need to make a knot in the medial, but after putting lateral, this is the final rotator cuff surgery. So the question is, what happens after this rotator cuff repair? You have a good restoration of footprint and would be healed. That's why this is what I would like to share with you. You know, have you seen this histologic findings? This histology is a normal bone tendon interface. This is what is called entheses. This is a special structure because this is connecting soft tissue of tendon to the hard tissue bone. So this transition between the soft tissue and hard tissue is a highly specialized structure. It's not really soft tissue, but it's not really hard tissue. So you see here, unmineralized fibrocartilage and mineralized fibrocartilage. Can you see how it is anchored to the hard tissue? It's like a root of the tree. And here's an interesting line, which is called tide mark. So this is a normal bone tendon interface. Then the question is, you see here degenerative tear, large size, chronic tear, you can't see any tissue remnant on the great tuberosity. It's really like a bald humeral head. But on this side, this is a young guy with a trauma. You see a lot of soft tissue remaining in a tuberosity and ruffled border of the tear. This is a rather acute traumatic tear. So what I'm saying is that this acute traumatic and chronic tear is completely different. Here's what you can say. This is a normal bone-tendon interface. As I said, tendon, bone, fibrocartilage, unmineralized, mineralized. So if you have acute repair of acute traumatic tear, you almost restore normal bone-tendon interface. You see the good organized fibrocartilage layer anchoring nicely to the trabecular bone. However, if you do a chronic tear repair, you see there's no organized mineralized fibrocartilage. This is only scar tissue between tendon and bone. So the question is, could we restore normal native bone tendon interface? Oh, it's a very, very difficult question to answer, but at least in an animal model, it's not really realistic for chronic tear. So we know how the fracture heals. After fracture, we have an inflammatory phase, soft callus, hard callus, and remodeling phase. Flexor tendon also has an inflammatory phase, proliferative phase, and maturation phase. So what do we know about bone tendon interface healing? So I'd like to share what we learned from the animal study. This entheses bone tendon interface, it has a 3 phase of healing. Initially, proliferative attachment, then anchoring fibrocartilage phase, and then maturation phase. So in a rat model, in a first week, you see the proliferation of chondroblast. There's no mineralized fibrocartilage organization. It's all scattered, disorganized. In the second phase, now you can see the fibrocartilage is standing all parallel. This is a second phase. And then third phase, now you can see the tide mark between the unmineralized fibrocartilage and mineralized fibrocartilage. This is the third week. So if we calculate into a human, in the first 6 weeks, it's an attachment phase. Until 4 months, it's a fibrocartilage formation. It can be unmineralized first initially, later on mineralized fibrocartilage. After this phase, you have maturation phase. Maturation, it takes until 6 months. So maybe you can consider when you treat your patient, what we should do after rotator cuff repair. So how to treat massive rotator cuff tear? It's a very difficult topic, but here's my suggestion. You need to always think about at least these 4 factors. You need to think about whether this patient is right for surgery or wrong. What kind of stress do we have for massive tear? What about the condition of rotator cuff? What kind of surgical technique I'm going to apply? At least the 4 decision making is important. In a pre-op x-rays, we have to know what the migration of humeral head. Is there any glenohumeral arthritis? Is this migration reducible by manual? This is something we have to ask ourselves. MRI is very important when you plan surgery. We need to know the size of tear, anatomic involvement, whether it involves anterior superior, posterior superior. Retraction of the tendon is important, and muscle atrophy, fatty degeneration is a very important issue. So how to manage arthroscopically? This is one interesting case, 53-year-old, rather very young, at least in this community. He had a shoulder pain 5 years, farmer, you see the humeral head is actually articulating with the acromion and the migration of humeral head. There's no rotated curve and retracted to the glenoid side. And subscap, you can't see anything. So for this young guy, what you can do, we did lots of microfracture, lot of release, medialization, and single row repair. Then you are very, very skeptical on healing for this large sized hair. But the outcome is unbelievable. Healed very nicely with the single row repair, medialized anchor, and the microfracture had a very good fibrocartilage on the lateral side. So the complete repair actually is the best option for massive rotator cuff tear. But this is the JVJS guideline. You can see the most reliable is complete repair. Partial repair is inconsistent result, so I'm not doing partial repair a lot in my practice. But as you can see here, non-operative treatment like Mr. Copeland's anterior deltoid strengthening exercise is helpful for sedentary, elderly people. And for pain control, biceps tenotomy is very useful. Tendon transfer mostly for the young, active patients. And tissue augmentation repair and debridement only is not really consistent. The result is rather below to the this B. So for complete repair, arthroscopic visualization is very important. This is a scope from posterior, and this is scope from lateral. You know the difference. If you put scope from posterior, you can see very nicely here anterior, but you cannot really see the posterior lip very well. But if you put scope lateral, you can visualize anterior posterior nicely so that you can debride the necrotic tissue clearly. So any arthroscopic surgery, visualization, complete visualization is most important, and easy access to the anterior and posterior margin is very, very important. So as you all know, the mobilization is very important for massive tear, and coracohumeral ligament is the structure you have to release as a routine, and superior capsule release bursa side and articular side on both sides, and interval slide sometimes helpful to repair it, but I'm not doing interval slide very often. Here, what I would like to say is you probably think about the posterior capsular release as a routine if you see the massive tear. This posterior inferior capsular release is very important because why? The anatomic study using cadaver shows here if you have a tight posterior capsule, as you lift your arm, your humeral head migrates posterior superior, and it makes dynamic functional impingement, and it makes your repair very, very fragile. So if you see any patient with the massive tear, posterior capsular tightness like this, you always release posterior inferior carefully. And the next technique you can use for massive tear is side-to-side repair, marginal convergence. This margin convergence is basically convert large U size to a smaller, medium-sized tear. This is anatomy, what this anatomy book said. You need to repair side-to-side marginal convergence, and then later on, this repair. But if you think about the anatomy, you see this anatomy study by a Sugaya Japanese group. You see the supraspinatus is attached only very front. Majority fiber is coming from the infraspinatus. So that if you see the rotator cuff from above, majority comes from posterior superior to the anterior side. So when you do a marginal convergence, same concept. rather than doing transverse, horizontal, you need to do a bit more oblique convergence. So your rotator cuff, at least the infraspinatus, can work better than before. So this is how we do. You pull this posterior part of a rotator cuff, and then your marginal convergence should be very oblique. So the posterior superior comes to the anterior so that it can be more anatomic. So oblique convergence is something we can remember. And massive rotator cuff, if you look at the textbook or literature, you have all different options. But actually you are not sure which one would be better than the other. What kind of indication, how we should do debridement or tendon transfer or patch graft, what we should do. But nobody has a clear answer for that. But at least you need to have your own experience to build up your own clinical result. Debridement, tuberoplasty, partial repair, result is very inconsistent. Patch graft is still evolving. Reverse total shoulder is very radical sometimes. So here I would like to share SCR, superior capsular reconstruction, as a treatment option for massive rotator cuff tear. Actually, Dr. Akshay Kapra is a big supporter of SCR when he was with me in South Korea, and we evolved the surgical technique since he introduced this concept. So basically, superior capsule, once you have an intact superior capsule, during your arm elevation, this becomes your static stabilizer on top of humeral head, and your fulcrum is moving properly. But if you don't have a superior capsule deficiency, then your deltoid will work as a shearing force to the humeral head, and it makes grinding to the glenoid. So it's very different from the conventional patch graft, because conventional patch graft connects torn supraspinatus and to attach to the great tuberosity. But superior capsular reconstruction makes capsule one in the glenoid side, the other in tuberosity side. So basically you have capsule on top of this glenoid to the tuberosity, so that your tissue upon this capsule can be grown to the graft capsule. So if you look at the literature, the Mihata, who is a good friend of mine, he published very good result, clinical follow-up, 25 shoulders initially, but now 30 shoulders over 5-year follow-up, retear rate is 10%. But unfortunately, Mihata is the only one who have this successful result. So long-term clinical result is not still found. So number of issues you can ask for SCR, but here's our experience which I would like to share with you. The indication, first, you shouldn't have any severe osteoarthritis, because whatever you do, soft tissue, arthritic pain cannot be resolved. So we do a Hamada 1, 2, 3, early 4, but advanced glenohumeral arthritis is not very good indication. Any patient aged 75, two things: you can trust the fascia lata, because their fascia lata is really paper thin, and you can trust their bone, because the anchor screw pull-out complication is very common, and they cannot tolerate that long rehabilitation. So this kind of advanced fatty degeneration, massive chronic retracted tear is a good indication. But you have to remember that the manual traction is important. So any fixed humeral head migration, you cannot deal with this SCR surgery. So this is a case, a 65-year-old lady, right shoulder pain. You see the migration of humeral head, very advanced fatty degeneration, and retraction is very advanced here. So this is the fascia lata folding, autograft folding and graft. And here's our surgical technique. So right shoulder beach chair position. So right thigh, great trochanter. We make a longitudinal incision. You have to know the posterior fascia lata has a thicker graft. So we make a double layered and sealing the fascia lata and then mark with the ink so that it cannot be twisted inside. So this is the graft which we should put into the glenohumeral in a subacromial space. First, glenoid preparation, and then we put 3 anchors on the glenoid. Or you can put 2 anchors, but we change to the 3 anchors because 3 anchor, you actually can expect equal force transfusion to the glenoid side. So usually 12 o'clock, 10 o'clock, 2 o'clock, we put 3 anchors. And then, of course, biceps tenotomy. With the biceps, you cannot do SCR. And we do a footprint preparation, but here's how I would like to say. If you have any remaining soft tissue, do you debride all, or is it better to preserve some? We do debridement, but we do very, very minimal. If you have any soft tissue remaining, looks healthy, we try to preserve, because our primary repair said preserving the soft tissue on the tuberosity, you actually have a better result. So after debridement, we pull all these stitches to the lateral portal. Now 6 sutures on the lateral portal. Now we pass all these sutures through the graft. Now this is how we pass this graft into the glenohumeral. Like a zip line, if you pull on the lateral side, the central part of patch goes in. This is the most tricky part of surgery. So after passing this graft into the glenohumeral joint, you find the suture one by one and make a knot. So we finish this glenoid side sutures and pull the tail to the lateral side and then put the medial anchor first. This is a posterior part. We put 1 anchor, medial anchor, and then put the anchors. So we make mattress sutures on top of this graft. So the tension is a very important issue we can discuss later on. And 1 more anchor in the front. And then again, we pass these sutures through this graft. And then we tighten up. Then now we have secured the graft in a glenohumeral joint. So if you have any time, we can do a biceps tenodesis to avoid any cosmetic issues like to avoid the Popeye deformity or additional soft tissue healing on there. So now we secured this graft to the shoulder. This is not the end. What we changed so far is we pull this remaining bursa tissue, because bursa is very fragile here. But bursa has a lot of extra capillaries or vessels. So this is a very good biologic bed to cover this graft. So this is not the rotator cuff. Remind you, this is not rotator cuff, but we carefully pull all this bursa on top and then cover this graft. Then we make a lateral knot, and this is the final construct. So if I summarize again, put 3 anchors on a glenoid side, pass this graft, make secure fixation on the medial and the lateral side. Then we pull this bursa on top and then fix this on the lateral side. This is what they call the bursa over the top, so that this bursa can be a healing source of this graft. So what is the result? This is a pre-op. This is a 3 months post-op. This is 9 months post-op. Can you see the thick graft over this humeral head. Patient had a very good range of motion and functional score. And you may ask, does it really improve functional score? Yes. You can have a look. This is a midterm clinical outcome. The pre-op, post-op, absolutely it gives a better functional outcome. And what about the MRI? Does it really sustainable inside? According to our MRI midterm clinical outcome, the failure rate is almost 60 to 70%. But when you look at this failure, majority on the medial row, mostly in a medial row. So why medial row? Maybe it's because of the high tension or less blood supply. So this is not still something I cannot answer you, but the highest failure rate was on the medial row. So when this graft fails, according to our serial MRI study, majority within early 6 months. So mostly in early 3 months, they have failure, and another 20%, 3 to 6 months. So once it is over 6 months, you actually can be safe. So the bottom question is, I mean, other than Mihata, why we have such a high failure rate? American shoulder elbow surgeons, they report the SCR failure rate is 65%. It's a huge number, 65%. But their graft is a bit different from Mihata from Japan. So what is the solution to avoid this high failure rate? That's why we had a systemic review, which we published before. But you know, if you look at the literature, this is all we searched in PubMed. Among almost 600 cases, unfortunately, mostly less than 20 patients, less than 12 months follow-up. So the result is not really reliable, even though it has been published in a PubMed. So other than this unreliable result, we could find 6 papers, including Miyata, 100 patients, Lee 36, Denard 59. But here we have 2 reports, Dr. Lim and myself. The result, midterm, very good. Not very good, but very favorable. So do we need to change our surgical technique? Yes. How we change our surgical technique? We need to think about the biological and mechanical aspect. Graft preparation changed because sometimes, elderly people, we could not trust this thickness of the fascia lata. It was rather thin. So is this fascia lata really strong enough to resist humeral head migration? Yes or no? That's why we applied this mesh. This mesh is used for general surgeon in a hernia surgery to fill the defect, or oftentimes in an orthopedic tumor surgery, we use this a mesh to augment this tendon to the artificial prosthesis. So we apply this mesh graft in between this fascia lata. So even though your fascia lata is very thin, once you have this polypropylene mesh inside, this has enough biomechanical strength and good tissue ingrowth as well. So until 2016, we only used the fascia lata, okay? After 2016, we used the fascia lata plus polypropylene mesh. So SCR before 2016, after 2016, different. So we would like to see whether it really provides better result. 34 patients before, after 30 patients. So if you look at this pre-op demographic, okay, mesh group or fascia lata only group, the result, the 2 groups are pre-op more or less the same. But here's interesting. the pre-op MRI data, the advancement, acrohumeral distance is all similar. Okay, so basically these two groups are same group. The clinical outcome, yes, good. Post-op clinical outcome, ASCS score, range of motion, it's good because this white is fascia lata group, this red is mesh group. The final outcome is good, but what is different is the clinical outcome improvement is different. This mesh group has a lot better improvement after surgery. Pain score has a lot better. Range of motion is a lot better. So this is a significant difference. What makes this a significant difference? This may be explained by this our MRI outcome study. So these two groups, when they compared at the final outcome, the healing rate is a lot better in a mesh group. You see 83% and 67%. Sorry about that. The graft healing rate is better and graft failure on glenoid side is no in mesh group. Early graft failure in mesh group is a lot less. Thicker graft, wider acrohumeral distance. Okay, so at least once you use this mesh, you can avoid early failure and you can sustain that acrohumeral distance. So this is a pre-op MRI, post-op MRI. This is 6 months post-op MRI. You see the retracted cuff. Once you do fascia lata graft, you see the inside, you can see the porous. This is a mesh, and on top, there's a fibrous tissue ingrowth. This is a double layer sign we said. Once you use the mesh, it resists the humeral head migration. And post-op MRI, this is 14 months. Can you see the thick graft, this dense fibrotic tissue in there? And this is only fascia lata group. This is with the mesh group. So will it stop rotator cuff arthropathy? I mean, the SCR can really delay the cuff tail arthropathy? Yes. If you have a failure, yes, it goes, to the arthritic changes. But once you have a healing of graft, you actually have a less cuff arthritis. So at least as long as your graft heals, this delay arthritic change, or it can pause the arthritic changes, which is very stimulating for us. Can you see the failed graft here? Pre-op, 18 months post-op. Can you see the migration? And this humeral head is articulating with the acromion. Student, but there's a little bit of migration of humeral head. But if we have a healed graft, this is a pre-op, acromion-humeral distance is almost no, but you see 20 months after post-op, no arthritic changes. What about the fatty infiltration? If you have a successful healed graft, the muscle wasting, atrophy, is not really getting worse. Of course, if it failed, it goes worsening. So is really SCR good enough even for elderly people? So the definition of elderly people can be different, but we had a indicator 65. Yes, fascia lata group, the integrity, it decreases. If you use only fascia lata, as you get older, you have a less healing chance. But if you use mesh, it's not important. Even though you have age over 65, still success rate is very high. So this is a patient, a 77-year-old. You may argue that we have to replace this shoulder, but still joint replacement is not a really option for me yet. So 75-year-old, still, once you have a good successful SCR, it sustains this glenohumeral joint. these elderly people over 65, post-op failure, yes, but still arthritic change didn't really progress that much. So even though you have a failure of the mesh, the gap size is not as big as before. So maybe this is how we can have a good range of motion even though we have a failure. So if I summarize, massive irreparable rotator tear, you have all variable options. So what will be the most reliable? Of course, the complete repair is the best option, but if you cannot do a complete repair, better than doing partial repair or debris mount only, I think SCR is quite a good option. So midterm graft failure is only 30%. Even though you have a failure, their arthritic change is not really severe enough. And medial row is still most weakest link. And age is not an issue anymore if you use a mesh. So rotator cuff arthropathy, you actually can delay if you have a successful result. Fatty infiltration and muscle wasting is not serious enough as long as you have a graft intact. Thank you very much. This is what I prepared, Ashay.
Thank you, Professor John. It is an excellent presentation with lots and lots of insight into seemingly difficult surgery, but you have made it very simplified in a very stepwise manner. And we can clearly see how your surgical technique has evolved since the time when I was present and since the time Prasad sir was there. And definitely incorporation of a mesh has given you advantage of using only a tensor fascial autograft or using a tensor fascial graft augmented with a mesh. There are a couple of yes.
Is that SCR popular procedure in India?
It is gaining popularity now. If I can word it correctly, it is right now a melting pot. Okay, so we are trying to use there are lots of techniques which are coming up. I mean, people are doing their own variations of SCR.
So what about the SCR arthroscopic procedure and the reverse total shoulder? And what is the popularity in India?
Of course, SCR, I mean, people will go for an option of a superior capsular reconstruction before undergoing a reverse. Elderly patient, right, as you commented, that if you have got a completely fused joint and it is not reducible, then in a cuff tear arthropathy, completely arthritic, it doesn't go away with any kind of a soft tissue procedure. In those patients, yes.
Number of reverse total shoulder is getting increasing now.
Yes. Now it is getting. Yes. So you said that all of your previous cases from 2013 to 2016, they failed at the medial row, right? So majority of them, the re-tear was at the medial row. So any chance that if we use a slightly less tensile fiber, or if you're using fiber wire or fiber tape for using on the medial side, if you use a slightly low tensile tissue for low tensile suture material for the medial aspect, will it have some kind of a how can I say, less load on the medial aspect, and then we can experience less re-tear? What is your opinion?
Yes, Akshay, I think that's a very important point, because every time when we do a double row, we're always concerned on the vascularity on the rotator cuff, especially if you make a tight knot on the medial side, the tendon is really ischemic. So I think it happens to the graft SCR too. Once you have a very tight mattress stitches, 4 stitches, you have a less chance of tissue healing, and then it becomes very inflamed, and later on that is the weakest link. So you see, according to our research work by my Chinese fellow published a paper in AJSM, what he said was, if you load if you put a lot of stitches on the medial side, that the knot on the tendon, it is triggering this chronic inflammation, acute inflammation and later on chronic inflammation because it's definitely a foreign body. This foreign body reaction, it makes your tendon very weak. So later on, this is making a chronic granulation tissue around, and that is the most weakest link. So now in my practice, as I showed briefly in a slide, I'm not making a knot on the medial side anymore, so that minimize this foreign body on the tendon so that tissue can be healed better. But still, I need a better contact of the graft to the tuberosity. So I'm still making a knot on the medial side for SCR. So what about your idea, Ashay? Do you think if we don't make a knot in the medial side would be better in terms of vascularity and strength of the graft?
The previous cases where I have done a superior capsular reconstruction. I have used the Arthrex suture bridge. This one,
Oh.
it is completely. I mean, you need not tie any knots. You can directly put medial anchors, take the tape out, and put lateral anchors. So that provides as Nihata does. But yes, I mean, I'm going away from the medial row knots. Okay, and that is really, I mean, in those patients I have got good results and there was no failure, but I am following up and we have an issue with the follow-up and repeat MRI, but so far those patients have done well.
I have a
those patients have done
Dr.
Prasad, you are asking something?
Yeah, I have a question. I mean, can it be related to the length of the fascia lata that we basically fold? So now what happens if we take a bigger graft, I mean a longer graft, and keep it a little lax compared to what we usually do? I mean, would that decrease the failure rate if we keep it what happens if we keep it a bit lax compared to try to get the tension back? And the same principle that we use for a rotator cuff tear, we want to have the repair under less tension. So what happens if we keep the graft a bit loose? I mean, is it going to decrease the tension on the medial row?
Oh, Dr. Prasad, that's a very important insight, which I really forgot to tell you. Because people were talking a lot about the tension of this graft for SCR, but we have to confess our surgical environment. I do a beach chair with a traction device, and can we really measure this tension properly in that situation? But I do agree, Prasad, tension-free repair is a #1 principle we should keep in mind for rotator cuff surgery, because any tissue under tension, you have a less chance of healing. So I'm still controlling this, adjusting the tension of the graft. That's why, lifting up and down and see whether I can have excessive tension. But you are very right. But one one downside is if you have a really lax, loose graft, it doesn't really resist this humeral head downward. So I have done it was a surgical mistake. I have a very long graft and then, put a less tension on the grind. The initial x-ray looks very nice, but after a few months of rehabilitation, slowly there's a little bit of abrasion in a glenoid on the surface of acromion. And then this patient had a very delayed tear. It was not really big tear, but slowly that graft becomes thinner and thinner, and then you have a little bit of perforation. Of course, we are not operating to make the MRI better, but at least that this is something we can think about. But you will hear a little more interesting story. We are preparing a now comparative study. I myself doing a bit more tension, and my colleague is doing a very redundant SCR intentionally, because that's how we think, because he believed this is more likely interposition arthroplasty. So you have a thicker graft, lose tension, and then it will sustain better. So you will see, we will see how the result. I think we probably can suggest you a better surgical technique. So Ashay, when you do SCR, how do you control the tension of the graft?
There are two things. I mean, after coming back, I'm doing all my shoulders in lateral position now.
Okay.
So, so the traction device, I asked my assistant to really drop put pressure on the arm, and I do whatever the knot I tie. Usually the arm is adducted rather than abducted. So that is the only way. And post surgery, I'm keeping them in slight abduction. I mean, with the abduction pillow 30 degrees for 6 weeks, and I'm going really, really slow about rehab. So that is the only way I'm controlling the tension. That no, I mean, no, I'm not tying my knots in abduction at all. So that is the only way I can control the tension. So I know how far my graft is going to get stretched when the patient is going to adapt.
Right.
So
right.
That is my criteria.
Yeah.
So that makes me. Sorry, go ahead.
What other procedures you do for massive rotator cuff tear? You do a biceps tenotomy only or debridement only? What else do you do?
I do a biceps tenotomy and a tendodesis. Recently,
Only simple procedure.
yes, only simple procedures. We are, I mean, I've done couple of biceps tenodesis in which we have incorporated, I mean, cut the biceps and use the biceps medial aspect, the glenoid tubercle aspect as a modified SCR for a massive, and repaired the rest of the cup. But the reports, I mean, I don't have a long-term follow-up of those cases as yet, but I'm following those patients closely. Let's see how far it works.
I think that's a great option too. You can use this long head of biceps as long as it has a reasonable thickness and condition. I think you can use this long head of biceps as a graft. My colleague is cutting the biceps rather distal here, and he is pulling this biceps into the joint, same as like our hamstring. So he can use this very long head of biceps as a SCR. So just like a zigzag like this. I think we can share that his surgical technique in your WeChat.
Another thing is how long, I mean, what is your post-operative protocol for your patients with a superior capsular reconstruction? And do any of those patients in which you have used mesh had any issues with the usage of the mesh? Was there any, I mean, increased synovial effusion, anything pertaining to that?
Yes, that's very good question, but I deleted that part of slide intentionally. SCL, same as like you, I do very delayed rehab because what I need is to avoid the early failure of SCR. We need at least 6 to 8 weeks in a shoulder immobilization. So we need a good proliferation of the scar tissue in the early 6 to 8 weeks, okay? And then I do a gentle range of motion exercise, but mostly this is a massive retracted tear. We can have a very good range of motion afterwards. So, I mean, stiffness is not really an issue for SCL patient. So as for mesh, what if it makes any foreign body reaction? Is there any chance this polypropylene make some arthritic change or foreign body granulation tissue or something? That's why we did an animal study. The animal study said, no, it gives a very good fibrotic tissue ingrowth, but it's not really harmful, something like a granuloma or something. And even though you have a little bit of a flick, loose bodies inside, the cartilage damage is not that severe. Only very superficial cartilage wear and tear, but I don't think that can be very clinically relevant. So that important issues, how it works, but at least you better to avoid this mesh directly to the articular cartilage. That's why I use it as a sandwich, seal off completely with the fascia lata autograft, so that this is really a tissue ingrowth and initial strength, okay, rather than this will be a, replace this rotate curve or superior capsule. Okay.
One more question is that there is a lot of debate about regain of strength. Like, do you really regain strength after a superior capsular reconstruction, or is it only the motion that you get? And do you really attach the posterior cuff to the graft when you repair it? And how far is the strength recovery as compared to the pre-op cases?
Well, yes, that's a really important issue we should address when you plan a SCL, because I always tell my patient, we cannot guarantee strength to your shoulder, okay? What we expect is reasonable arm elevation, pain-free, and to avoid your arthritis, but you cannot gain very good strength. But it's interesting. I do this surgery mostly for elderly people. These elderly people, once they have a pain relief, okay, once their pain is gone, when they start their elevation, I think they gain deltoid power a bit better than before. So I think it's a very palliative surgery, but once these patients, they get good pain relief, their arm elevation is much better. But you got the point. Their external rotation strength, no, I don't think they gain good external rotation power. Mostly their external rotation comes from posterior deltoid rather than infraspinatus, because infraspinatus is already gone. But I don't really attach this infraspinatus to the graft, because oftentimes it makes this graft, wobbly like that. So I'm not really suturing. What do? You spend some time with Dr. Miyata in Japan. So how his practice was like, and what was different from your practice?
I was not with Professor Miha. I was with Dr. Kuroda, and yes, I had a chance of meeting him. So he usually attaches the infraspinatus to the posterior aspect of the graft. And what they are telling is that, I mean, there is no grain of strength. I mean, that's what the debate is all about, whether you get the strength or only range of movement. So range of movement, yes, but the strength is not coming back. That's the issue. What an interesting thing which I learned with Professor Kuroda was they are doing the infraspinatus slide. They are peeling off the infraspinatus from the scapula. Okay, so that's how they gain some length of the tendon and they are able to attach it more. So if that is a completely different surgery, but if we can use some aspect of it to SCR, I think we will be able to provide increment. I mean, some increment in amount of the tendon which is available for reattaching at the tuberosity of the infraspinatus. So that's where we can provide some amount of external rotation. Their results are yet to get published, but I think they have a pretty good follow-up, and some of their patients did very well. Next question is that how, of these cases of SCR, were any of them converted to reverse total shoulder? And how easy or how difficult was it? Any technical tips about that?
Well, actually, this is not all my series. I had some failed SCL, which has been converted to the reverse by some other surgeons in Seoul. So I know some patients, they have a reverse shoulder because they cannot really have a good range of motion. But surgery is not very complicated. But again, any revision surgery, you have a risk of infection. That's sure you have to keep in mind. But I had a rather uncomfortable result with the SCL with allograft.
Oh.
Because I had a few, I think less than 2-digit number SCL using Achilles allograft. Because at that time, I believe that can reduce this, the the autogenous fascia lata, you can avoid, the complications. But now I'm not doing that allograft anymore, even though it is very possible in this country, because the SCR, they using Achilles allograft, they mostly have early failure. It doesn't really have a complete resorption, but I have done some second look arthroscope. All those patients, they all have a failure somewhere in between. Because this allograft, they become very, very paper thin, and I cannot see any tissue ingrowth on top of that. So I had a now confidence that autograft is a lot better. You have a less reaction other than this allograft. So I do an autograft with mesh as my, SCR standard procedure. So what about you? Do you have any experience with the allograft to SCR?
No, I don't have any experience with it. Dr. Prasad, how about you?
No experience with an allograft. But what I wanted to ask is that apart from suturing the bursa and taking the infraspinatus, not for the strength, but for increasing the vascularity,
Yes.
is there any other method where we can augment the biology, like using a fibrin clot or things like that? What about using a fibrin clot for augmenting the biology?
Prasad, that's a very good point. I'm not sure whether that is available in India, but here in this country, that kind of a biologic augmentation is a very, very big issue. And a lot companies, bio companies, they produce collagen patch and collagen with some stem cell inside. They have all commercial products now available for tissue ingrowth. And even in my lab, I'm working with the biologic department, how I can have a good tissue cell scaffold, some stem cell scaffold tissue ingrowth for SCR. So I think definitely it's for our future to have this, SCR or rotator cuff surgery, because still I believe rotator cuff surgery for massive, especially for massive, the result is very, very disappointing. If you do, using various techniques, you can repair it, but healing is a completely different story. You can repair it in your view, but that's day one. But you do not know what is going to happen after day 2 and day 3. Right. So how to avoid all these complications? I think tissue biologic agent or adjuvant augmentation, I think that's, I'm quite sure is for our future.
I have
Ashay,
one.
do you have any augmentation? Augmentation?
No augmentation. No. I have one question regarding the technical aspect. I mean, so how do you mark your sutures, or how difficult or easy it is? I mean, after so many surgeries, in the initial period, I used to remember that we used to mark those sutures. So I would like, for the sake of the participants, to make them understand how you manage your suture. What is your suture management when you are doing a superior capsular reconstruction?
Oh yes, that is still, we are learning every day. But suture management, there's no golden royal road to do. I mean, but still, I mean, you need a very good teamwork so that your assistant knows which suture is which one, and I'm helped by my residents and fellows. So I have no comment how to do that, but at least your assistant should be the same level as like you in terms of understanding the surgical procedures. So suture management, they have to help you. Otherwise, you alone to deal with, that many sutures, it's not really a good idea to do.
So when you're harvesting a graft, autogenous graft in a V chair position, is it easy to go on the posterior aspect to take out the tensor fascia lata, or you do any different position? You tilt the chair or tilt the table more? Is anything you're doing differently?
Well, in the beginning, I tried to do a little more, patient laying down and then tilt operating table and to expose a bit posterior. But now, I mean, people are very comfortable doing that. So I'm not really changing sitting position here and there, but still, I know it's not really as good as the lateral position, but the only disadvantage is that you need the time to harvest the graft. Then I can do the surgery. So it's like we had one assistant is harvesting graft, surgeon is operating. That's the weakness, actually.
So any issue with the graft site, any issue of graft site morbidity that you would like to highlight upon, or any complications related to it?
Not really, but you need to really explain your patient well that the pain may go 3 to 6 weeks and you have a little bit of a numbness here. And I had one case, temporarily seroma formation there, but not much. Mostly once you are explained well, they can tolerate very well. So I don't have any patient who complain that much.
Dr. Prasad, you have any questions?
No, I'm just okay.
So we have
what do you
already
think about what do you think about the long head of biceps as for SCR would be really a good option?
with the available length. I mean, you have highlighted a very good point that at what portion or what position it should be harvested and how much length is available. And moreover, I mean, I'm not very sure about it yet. I mean, I'm awaiting the long-term or the mid-term results of biceps as a SCR. Many people are proposing it, but right now we need to just wait and watch. I think what your data and Professor Mehata's data is there. If we look at the numbers, I think that should be the indication of what route we should take and what surgery we should be offering our patients right now.
Yeah.
So we have almost like 200 delegates around the world who are logged in right now. And we are very thankful, Professor Inho, for your insights on a massive cuff tear and your extensive study of superior capsular reconstruction with inputs such as using the mesh for avoiding the medial row failure and as well as the failure at the glenoid site. I hope that we can invite you again for many more sessions and we can have your insightful understanding of the subject of cuff repair. Thank you. Thank you, Dr. Neeraj. Yes.
Yes, thank you very much. Thank you, Dr. Jeon, for sparing your precious time. It was really a very good session. And the histopathology slides and the videos were really out of this world. For me, who's not doing shoulder scopy regularly or not doing at all, because Prasad and Ashay do it for me, it was something first time I have ever seen these type of slides. Thank you very much and good night to you and good evening to all of us. Namaste.
Namaste. Thank you very much. Thank you.
Don't log out. So